Good afternoon, good morning, good evening, whatever's appropriate for whatever time zone you're in. Welcome to our webinar on the future of space medicine. My name is Rand Simberg. I'm representing Space Tech Analytics. Space Tech Analytics is a subsidiary of Deep Knowledge Group, and this is a topic that our organizations are very deeply interested in because Deep Knowledge Group has started out studying longevity, and we found that there's seems to be a lot of correlation between problems with health in space and longevity. And in effect, it seems that when you spend time in space for any significant period amount of time, it ages you. Fortunately, with space, you can be rejuvenated by simply coming back to Earth. But that's the reason that our organization is interested in this topic. And so with that, I'm going to introduce Rhys O'Mahony from Oxford, and he's going to moderate our event.
Yeah, hi, cheers, Rand. So yeah, I'm Rhys O'Mahony. I am the president of the Oxford Aeronautical Society. So we're a student-led organization that try and aim to promote the interest in the commercial and academic and technological innovations in today's space industry. And then we've partnered up with the Deep Knowledge Group to put together this talk discussing that. So the past century has seen humanity take leaps and bounds in the field of medicine. So from sequencing the human genome to the eradication of smallpox, science has allowed us to achieve feats that were once thought impossible. Coming into the 21st century, this trend has shown no signs of slowing down. So advances in the sophistication of our computational and mechanical tools have allowed us to increase the rate of scientific discovery by orders of magnitude and enabled us to act on these findings as well with a newfound precision. So, but what is the next frontier of medical research? Where will we see the breakthroughs that are going to define the 21st century, and how are we going to achieve them? So we believe that the answer to all these questions about the future of life here on Earth lies in thinking about the future of life in space. So space medicine sounds like a fairly esoteric domain of interest, but advances that are being made and attempted to be made today are actually surprisingly relevant to our lives here on Earth. So the recent reductions in launch costs due to companies like SpaceX and Rocket Lab have made the commercial prospects of space suddenly much more viable. So as a result, this decade is set to see a dramatic increase in the number of people who are not only visiting space, but are living and working there for extended periods of time. So almost all of the people who've been into space up to this point have been extremely fit, highly trained professionals. However, we have very little data about how everyday people who are going to be working in space in the future will actually be able to cope in those environments. So, so in the process of gathering all this data and understanding how our bodies react in space, it will undoubtedly be valuable for the rest of the medical field as a whole, and give us greater insight into also how we would feasibly go about establishing permanent human settlements on other worlds. So increased knowledge in our bodies not only allows us to bring people's health up to the norm, but raise what we consider the norm as well. So as Rand mentioned earlier, we're beginning to understand that there is a surprising amount of overlap between the effects of aging and the effects of long-term space flight. And the hope is that in the process of solving one of those, we will help to solve the other as well. So the effects that space has on the human body are not just physiological, but psychological as well. So it's important for us to understand the sociological effects that arise from large groups being confined together for extended periods of time, so that we're prepared to be able to deal with the advent of larger space settlements. So at present, no more than 14 people have been in space at the same time, and that was only for a brief instant. How will we handle crews of hundreds or thousands of people all living and working in space together? So this is all, however, just the tip of the iceberg. The prospect of our long-term habitation in space has forced us to rethink not only medicine, but pharmacology, agriculture, communications, and artificial intelligence, just to name a few. So without further ado, we are going to get straight into these topics with our first guest, Professor Tyus Russomano. So Tyus is a Brazilian doctor and scientific researcher specializing in space medicine, space physiology, and biomedical engineering, telemedicine, and telehealth. She founded the Microgravity Center at PUCRS University, Porto Alegre, Brazil, in 1999, and coordinated it for 18 years until 2017. She is now a visiting senior lecturer at the Center of Human and Aerospace Physiological Sciences and the co-founder and CEO of Innovaspace. So Tyus, I'll pass over to you.
Thank you very much for the invitation and the introduction. Let's see. Just let me know if you can hear me well and if you can see my slides. Is it okay?
Yeah, it's all good.
Okay. So talking about the future of space physiology and medicine, and this has been my area of work research for over 30 years. And something that's very clear to me is that we have a huge lack of knowledge regarding the female astronauts, how the human body and human mind of women react, let's say, to the environment of space. I was very happy to see that the World Space Week this year was dedicated to that, to the presence of women in space missions and space science. And so I will first start with a historical view of the presence of men and women in space, and you can very quickly see the inequality of that. And then I will cover, I'll present an overview, let's say, of the physiological and psychological changes that happen to humans in space. And then I will end with what we should do, to help astronauts in space and also to empower women in space science. So just going back in time to the 1960s, in 1961, Gagarin, as everybody knows, the cosmonaut from Russia went into space. For the first time, a human was in space. And very luckily, about 2 years later, Valentina Tereshkova became the first woman to orbit the Earth. So it was it started very well, I would say. Now, although the name of that at that time was managed space exploration, which gives a symbolic meaning to these flights, to the way that we are starting the exploration of space. And I prefer to call it as human space of exploration. Of course, at that time, there was a huge lack of knowledge in relation to how the mind and the body would respond to microgravity and, for example, radiation in a space mission. So it was interesting that after that good start, we had to wait 19 years for the second woman to go into space. So Savatiskaya became the second woman in 1982. And in 1984, she was the first one to perform an EVA activity. The United States, after Tereshkova in 1963, waited 20 years to send the first woman into space in 1983, Sally Ride. And by the 90s, you can see that it starts changing. The way that the space agents start approaching the selection of astronauts changed a bit. So we had the first British woman, Canadian, Afro-American woman in space, and also the Japanese. So many space agents were somehow realizing that women should be in the missions. But we had to wait to 2005 to have the first female commander. And to 2019 to have the first EVA performed by 2 women only, no men involved. So it is really a huge lack of knowledge. And when you talk about the future of human space exploration, we need to consider that we want to live and work either in the low Earth orbit or on Mars one day or on the moon one day. And for that, we need to have men and women, and we have to even reproduce in space to set proper habitats and colonies. So if you look at the gender inequality in the space sector, it's very visible that among like more or less 570 astronauts, only 11% are women. In terms of spacewalk, it's 210 men against 15 women. In the space industry, the workforce of women is about 20%. And in aerospace and defense, the CEOs, the female CEOs, it is also about 20%. And if you look at space tourism, that's the next step now, what is really happening, the hot topic nowadays in space science. We see that there are 3 main companies, and the 3 companies are run by men. So we are still having this huge lack of between men and women in terms of knowledge, and in terms of experience. I think that it is interesting to see that from the beginning of the space era till now, from the 1960s, the environment of the spacecrafts, they change a lot from an environment with very low pressure and high oxygen to what we had from 1981 with the advent of the space shuttle, and nowadays with the ISS. We have an environment that is basically, it mimics what we have here on Earth at sea level, except for the level of CO2. So all these men and women that are now exposed to the environment of space, they almost have the same type of environment that you have here on Earth. So if you talk about a mission an extraterrestrial mission at low Earth orbit, we need to be concerned about 4 aspects: microgravity, radiation, psychosocial aspects related to space flight, and the disruption of circadian rhythm, because we have in 24 hours 16 sunsets and 16 sunrise, which affect not just the mind of the astronauts, but also the biological cycles in 24 hours. Of course, if you go to the moon one day, we are going to have to deal with the environment of the moon. And if you go to Mars, of course, with the environment of Mars. But these are now the 4 main topics that space life science scientists should be concerned about. Another aspect, if you are going to have a short-term mission or a long-term mission, because the human body would respond differently. Our body systems will respond differently in terms of time to this hostile, let's say, environment of space, would be microgravity, radiation, so on. We have different body responses if the mission is about a month or 6 months or over 6 months to a year. So it's very important to identify these issues in terms of the timetable of a space mission. We also have, of course, the differences between men and women that we do not consider much in space, but you have to consider, because here on Earth we have several differences that everybody is aware of. Anatomical difference, the muscles and bones are, in terms of density, mass, are different. The immune system and hormones respond differently. We have the difference in the reproductive system, how the mind, the psychology is responds here on Earth is very different. The culture and social aspects of societies all over the world, men and women are, they have different roles, and also clinical presentations of diseases. So this that we have here, in fact, we are just exporting it to space. And if you do not understand very well these differences, we are going to have a problem in the future when you try to really colonize somewhere and live there for a long time. Human reproduction has to be, this taboo has to end, because we need to talk about sex in space, reproduction in terms of not just the delivery of a baby, but also every single step of pregnancy. It is very important to understand that, either with animal models that we have some knowledge about that, but more animal models to get to humans. We need to, if you want to have habitats on the moon and Mars one day, we need to have that knowledge. But as I said, men and women in space, they are going to face health challenges. And this challenge would be very, let's say, the body systems would react very differently. If you have these lines here represent different body systems, so the yellow one is the neurovestibular system, the red one is the cardiovascular system, and the bone, for example, is the blue line. So if you look at that, you can see very clearly that the body responds very differently. And this would be, this is very important to understand if you are considering short-term missions or long-term missions. For example, space motion sickness will affect astronauts or space travelers in the first 3 days of a space of exposure to microgravity, and this is a kind of disorientation of the brain in relation to the environment, as microgravity makes you, float in space, and so all your orientation in relation to environment around you somehow is lost. The cardiovascular system, the moment that you enter microgravity, starts reacting as well, but it takes longer, let's say, to get to its peak. As I said, the neurovestibular system, in 3 days, you have it somehow solved, but the cardiovascular system is much slower because you have this, with the lack of gravity, you have this shift or redistribution of blood and body fluids to the upper part of your body, creating this syndrome called puff face and bird leg syndrome. Somehow the cardiovascular system adapts. There is a shift, of the liquid in our blood, the plasma volume, it decreases about 12 to 20%. The heart becomes smaller, and you adapt. You have let's say, a cardiovascular space physiology. It is a problem sometimes when you come back to Earth and have to deal with less blood circulating in your body and with a heart that is smaller. Of course, this shift of blood to your upper body will affect the many pressures, the pressure in your eye, called the intraocular pressure, the pressure in your brain, which is interesting to see that it was observed in male astronauts, not in female astronauts, and we are still trying to understand the causes of that, but it's a very important area, very hot topic nowadays. We have the bones, as I said, and the muscles that are affected in microgravity, and it is a continuous, they are continuously affected. If there is no use of countermeasures like exercise, you are going to lose bone mass and muscle mass throughout the flight. And the bone mass, for example, you can lose in the lower limbs, especially about 2% of bone mass in just 1 month. You elongate your spine, so you can become a bit taller in space, you can have a back pain because of that, and you assume a different body position. You cannot just stand as you do here on Earth. Here is just a representation of the bones that suffer the most in space, which is from the waist down. That is when is where you have the bones that counteract gravity. And again, if you lose 1% of bone mass a year here on Earth, is a lot. In space, you can lose even 2% in some bones a month now. So it is a lot. The muscles, the skeletal muscles, also suffer in space, especially the lower limb ones. And even the fiber, the type of fiber that we have in our body, the skeletal muscle fibers, they can change from type 1 to type 2, because it's the function that is needed in space is much more related to the need to, let's say, to quick react to a situation than to stand. You cannot stand in space. And here you have just a quick representation of what of an astronaut in the semi-fetal position, and the muscles that are affected, the back muscles, the muscles of the legs, which lose power, strength, fiber size, and mass. So there is an atrophy of muscles. Human mind in space, I love that topic, is space psychiatry, space psychology is really very important. I think that in the introduction it was mentioned the confinement, isolation. I could add depression, monotony, sometimes overloaded of work. This difficulty with dealing with this light and dark cycle, as we have 16 sunsets and 16 sunrise in 24 hours. It was also mentioned the communication issues, the diversity of the crews, like different genders or nationalities, different professional backgrounds. So we need to understand not just the effect of the environment itself, but also microgravity and radiation in our mind to be able to really somehow live for long periods of time in space and properly work over there. But on top of all these changes that are expected, the psychophysiological changes that are expected in a space mission, short or long space mission, we have also the possibility of clinical diseases, which means that the astronauts, they are suffering, because they are in this environment that is hostile to them. And on top of that, they can have a skin infection, a respiratory disease, something that can really become a medical issue during a space flight. So what is needed? Just to finalize now, as we know, every single cell in our body, to the big body systems and the integration of all that, everything suffers in space with microgravity radiation. And one day with the hypogravity of the moon and the conditions of the moon, and luckily we can get one day to Mars, and also we have to deal with Mars. So first, of course, we need to train astronauts to first identify the psychophysiological changes that are expected to happen in space, so they don't get scared that someone is getting sick, for example. It's just an adaptation to that new environment, but also to identify that something is a bit off. So they need to be trained to collect data and send that to Earth. They need to be trained in some minor, let's say, medical procedures, minor surgeries, let's say, to help a colleague during a space mission. Of course, telemedicine is what we use in lower Earth orbit missions, and it is very possible because it is a real-time communication. The spacecraft, the space station, is about 500. Sorry, what's that? Sorry. How can I go back? Okay, sorry. 400 kilometers in altitude. So you have a communication that is a real-time communication. You can monitor the physiological change, for example, that the astronauts are experiencing in a mission, or even identify some clinical problems or guide astronauts in an emergency. Everything is going to be very, very different during a mission to Mars. And this is, when you talk about the future of space medicine, we need to be very careful about that, because in a trip to Mars, you're going to spend months in microgravity, exposed to radiation, 6 to 8 months to get to Mars, and then you stay on Mars for, let's say, 6 months or so, and then you have to come back to Earth, ideally. And besides that, you need all these physiological changes will be also accompanied by the psychological change and psychological change of 4 persons in a space mission, going to Mars and coming back. The communication will suffer a lot with the distance, because the distance will range from 55 to about 400 million kilometers, which will give a problem, let's say, in terms of communication, because the delay will be between 3 minutes each way to 22 minutes each way, which is really a problem for a quick help from the ground in terms of a medical emergency in space. So in my opinion, the only way to do that is to have a huge investment in artificial intelligence, wonderful medical health algorithms that can help astronauts to identify a medical issue, help to manage that, help with the diagnosis and treatment of that. So I think that that's the future. We even if you have a doctor on board, and I believe that we will have a doctor on board when you go to Mars, or even when you are living on the moon. Even in the moon, the communication will be basically a real-time communication, because the moon is about 300,000 kilometers from Earth, and the communication is at the speed of light. So it is not a huge problem, maybe a 1 minute, a 1 second delay. But to Mars, we need the help of artificial intelligence. And of course, with the space tourism exploding now, with flights, with travelers that are not proper, let's say, astronauts. We are going to have people less fit to go into space, older. We just had Captain Kirk going there with the age of 90 years old. So it is going to bring new challenges. As I mentioned, the challenge that we have now is much more related to the environment, to this microgravity, radiation, psychosocial aspects, and the circadian rhythm. Now we are bringing, because supposedly the astronauts are fit and healthy, but now we are bringing people that are not as fit, not as healthy, and maybe with chronic disease, taking medication and so on. So what we can also do in terms of empowering women into space missions, space science in general. So I think that basically we need to have more research in terms of in space with women. So we have to have subjects, volunteers in space, female volunteers, and we need to have more data. We have data based on male astronauts, so it's male space physiology, not female space physiology. Here on the ground, we also should include more studies that evaluate the gender influence on different topics. And this is just an example of one of my studies that I did looking at CPR in microgravity and hypogravity simulations. What is important here, I think, that is to, if you look at the publications, you are going to see that, that 90 or 8% of the publications you have male volunteers. I was very careful during all my research over many, many years, always to have two groups, one female and one male. And in terms of society, through my company, Nova Space, in alignment with the United Nations Sustainable Development Goals, quality education, which is the goal 4, goal 5, gender equality, and 10, which is reduced inequalities. I have some projects. I was a mentor at the UNOSA project, Space for Women. I worked with my mentees, three young ladies. We interviewed women from different regions of the world, trying to understand why these people that work in the space sector, how they see, how they perceive their let's say, position as a woman in this field. We have all these interviews done with people from Africa, Asia, and so on, and we are preparing an ebook with that. There is also the project Valentina, in honor of Valentina Tereshokova, which try to empower girls and young ladies towards STEM or STEAM with space science in the background. So we have lots of initiatives under the project Valentina. And just to finalize, the Kids to Space or Kids to Mars, which is another project, that outreach project that tries to empower girls again and boys as well, because we have a symbolic representation of the every single country in the world. So we want to get 193 countries represented. So it's a symbolic representation because you have a girl and a boy of each country asking questions about trip to Mars, the planet Mars. So it's focused on Mars. So that's my contribution. Thank you very much. I hope you have enjoyed. And I'll be here for questions later
on. Cheers to that talk, Tyus. It was very interesting. Thank you very much. Okay, and also cheers to the chat for being having so much engagement. I'd like to let you all know that you can post your questions in the chat, and we'll take them all together at the last kind of like 30-40 minutes of the talk, and allow our panelists to actually answer your questions. So do put your questions in the chat. We will try and get through as many as possible. Okay, so our next guest is Dr. Elisa Rafaela Ferro. She is an experimental psychologist and cognitive neuroscientist. She completed a BSc and MSc in psychology at the Università degli Studi di Pavia in Italy, and a PhD in psychology from the same institution in 2012, for the investigation of multisensory integration between vestibular, somatosensory, and visual functions in humans. She was a postdoctoral fellow at the Institute of Cognitive Neuroscience at the University College London from 2012 to 2015. From there, she took up her first faculty position at Royal Holloway University of London in 2015. And since September 2021, she has been a senior lecturer and the director of the Vestibular Neuroscience Laboratory at Birkbeck University, London. So passing to Dr. Elisa, I will give you the floor.
Hi, everyone. Hope you can hear me well.
Yeah, it's all good.
Okay, and hopefully you can also see my slide.
Yeah.
Just double checking. Yeah?
Yeah, all good.
Amazing. So, hi, everyone. I'm Elisa. First of all, thank you very much for attending the webinar tonight. And also thank you very much to the organizer to put together such inspiring and exciting meeting. So I'm going to talk about astronaut psychology and cognition, and I will go into some of our recent data about behavioral adaptation to long-term space flight and what are the potential implications. I hope that I'm not going to scare you too much with data, and if I'm doing so, please wave to me and I will try to explain in an easier way. So first of all, let me start to say that our brain, the human brain, is an amazing object, is incredible adaptive. This means that our brain can constantly adapt to new situations and demands from the external environment. And we are very good in doing that. So essentially, humans have been able to adapt to environmental circumstances here on Earth in an excellent way. And we call this ability behavioral adaptation, the fact that we are ready to react to what are the challenges from the external environment. Now, as we have heard in the previous talk, space is a completely different story. Advances in technology have allowed us not only to be in space, but potentially to live there. And space can be considered the ultimate frontiers to our ability to adapt to the external environment. So long-term space exploration can be a real challenge to the human health, because there are many different stressors that can affect human health: radiation, extreme temperature, the absence of atmospheric pressure, altered gravity, but also isolation, stress, and confinement into a small, limited space. Now, understanding how these factors can influence the ability to adapt to the external environment is very important. And in my research, I particularly focused on the brain response to altered gravity. And I think that this is key in order to ensure the successful and safe outcome of space mission, whether we are talking about long-term space exploration or whether we are talking about commercial space flight. So understanding how the brain responds to altered gravity, I think, is a fundamental question. So as Albert Einstein said, gravity is the first thing which you don't think about. On Earth, gravity is 9.8 meters per second square. And if you now think about that, it is a quite not so small linear acceleration. However, you can perfectly interact with gravity in all your behavior. So if you are drinking a coffee now, if you are moving around, if you are jumping for some unknown reason during my talk, anyway, you can do that in a perfect way, and your brain can adjust to this 9.8 downwards linear acceleration. So I can lift this glass of water almost with no effort, and my brain knows exactly how to send motor command to my hand in order to do a movement without effort. Now, we are absolutely great in doing this here on Earth, but as soon as we move to a different environment, a different gravity environment, such as Mars, things get much more complicated because the amount of gravity is going to be different compared to our usual amount of gravity. Now, how does the human brain encode gravity? Well, it does that mainly via this vestibular system inside the inner ear. So the vestibular system is deep inside the inner ear and can detect each movement of your head. Now, if you stay in an upright posture, like this one in the picture, and your vestibular system has these tiny, small little organs, which are called otoliths, which are perfectly on balance on a fluid. Now, they are on balance on a fluid and perpendicular to gravity. But let's say that you want to make a movement with your head, you are tilting your head in this way, for instance, then the situation gets quite different, because the presence of gravity is going to make a shift in the fluid, which is triggering a movement of the otolith. And inside this fluid, we have many air cells that are going to send an action potential directly to the brain and say, wait a moment, this head is no longer aligned with gravity. Well, not really in this way, but you got the idea. Now, our brain knows exactly the magnitude and direction of gravity by using this sophisticated system. And of course, the vestibular system is not the only modality that is going to inform the brain about the presence of gravity. There are also other important sensory information from vision, from proprioception and somatic system, as well as visceral. So this means that our human brain is taking all this sensory information and it creates an internal model of gravity, a representation of gravity, which allowed us to interact with the environment, which allowed us to lift and drink this glass of water. Now, as I say, this internal model of gravity is perfect for 1G terrestrial gravity, but as soon as we move in an altered gravity environment, things are getting a little bit more complicated. So we know that there are major effects of space flight on brain and behavior, and we know that from Astronaut's report. There are, of course, changes in brain structure, given the fact that there is a shift in the fluid. So the lack of gravity, for instance, on the ISS, is going to create a shift in the fluid toward the head, and this is going to compress the brain structure. It has been shown that there is a reduced connectivity, such as there is a reduction in the way in which different brain areas are linked together. And this reduced connectivity is particular in this blue area that you can see here in the brain. So here is an image of the brain, let's say, that has been cut in this way, remove the top. And then if we look into that, we can see this area here. And it's called insula, and is one of the key vestibular areas. So structural changes in the brain. And as we have heard in the previous talk, these structural changes are also accompanied with behavioral changes. For the first hours, days, and sometimes weeks, there is a very strong space motion sickness, which has been called space adaptation syndrome. So up to 80% of astronauts during the first period of time in the space flight, they experience a very strong motion sickness, nausea, vomiting, but also perceptual illusions and disorientation. Now, if you take all these different aspects, it's pretty clear that they can impact the performance of the crew in a significant way. And we know also that there are several sensory motor alterations, both in how the senses are processed, but also in how the motor commands are done. So here you can see, for instance, astronauts try to walk on the lunar surface, and you can see that even such a easy action for us, which is walking, can be strongly affected by a different amount of gravity. Now, it has been shown that there are changes in how we perceive the position of our body in space, which is called proprioception. There are changes in vision, which can get a little bit blurred, given the fact there is compression of the visual nerve inside the brain. We know that there are alterations in the balance, locomotion, and the coordination. There are changes in the way in which grip is exerted, the amount of force that you need to make a grip movement. And there are also problems in terms of eye-hand and eye-head coordinations. On the top of these sensory motor alterations, there are, of course, cognitive alterations as well. It's not easy to deal with a different G load. And perhaps not surprising, there may be cognitive effect, psychosocial issues, as well as psychological issues. So if we look at this big picture, I think it's quite clear that we need to find a way, we need to understand what happened to the brain and behavior in order to provide the brain some support during space flight. And in particular, if we are talking about long-term space flight as well as commercial space flight. So this is essential in order to ensure a good human performance during missions. Now, my research is looking into how ultragravity is affecting brain and behavior. And we do so by combining traditional space research methods, such as exposure to ultragravity on parabolic flight and human centrifuges, but also by doing quite a lot of lab studies. The reason why I do like to do a lot of lab studies is because then we can have a larger sample of participants as well as gender balance sample, as highlighted in the previous talk, and we can perhaps look a little bit more in depth into some of these mechanisms. We have recently been looking at how pain perception is changed by exposure to ultragravity. And the reason why we decided to focus on pain is definitely not random. So pain is another critical sensory modality, which has a very important adaptive function. It can protect our body. It can protect our organism. So we wanted to look at whether pain, and acute pain in particular, might change after exposure of altered gravity. And to do so, we have used a short exposure to head-down bed rest. So in head-down bed rest, you have participants on a 3D tilting table. They are attached on this table, and then we can passively displace them in different orientation. And in the control condition upright, participants are indeed upright, in which the head and the vestibular organs are in a position that is coherent with the direction of gravitational acceleration. While in the head-down bed rest, you can see here that the head is slightly lower than the feet, is 6 degrees lower than the feet. So we have participants in these two orientations, and then we measure their pain threshold. So we apply pain on the fingertip, and we ask participants to tell us when these stimulus start to get really uncomfortable, clear, painful. And as you can see here, there was an increase in the pain threshold. So each dot is a single subject. And overall, there was a significant increase in the pain threshold, which means that participants were feeling less pain. There was an analgesic effect when ultragravity was present. Now, we wanted to look further into this effect by using a different type of gravity simulation, which is a virtual reality simulated gravity. Now, we started to use virtual reality because I think that virtual reality is really cool. It's really a nice tool that we can exploit for this type of studies. Now, during virtual reality, the brain can easily get tricked by the virtual reality scenario. It's called visual capture, the fact that the brain can engage a lot with the virtual reality simulation. Now, we block the head of our participant, such as that vestibular cues are going to decay over time. They are not any longer so salient, and the brain can trust what it's going to see into the virtual reality scenario. And here, essentially, we simulate terrestrial acceleration or Martial acceleration. And we have measured the pain threshold while participants were looking at these terrestrial gravity or Martial gravity. And we found, again, an analgesic effect, such as that when participants were tricked to believe that they were on a different G level, on a different G load, they were feeling less pain. Now, this may be possible because of a conflict between the online sensory information and this stored internal model of gravity that I was mentioning at the beginning of my talk. Now, I would like for you to keep in mind that I don't necessarily think that being a superhero in altered gravity with feeling not pain is something good. Actually, it can be quite dangerous in terms of protecting the organism against external event. So we also wanted to look into the motor responses to environmental stimuli. It's very important to be fast in responding to stimuli from the environment. And we have used here something that in neuroscience we call auditory oddball task. What does it mean? It means that if you are a participant, you are going to listen to a train of several beeps sounds, hundreds of beep sounds. And 25% of time, there is a beep which is with a different pitch. So let's say that the train is low pitch beep sounds. 20% of time, there is a high pitch sounds, and you need to press a button as quickly as you can when there is this audible stimulus. It has been shown that if we do this task into an fMRI scanner, several brain areas, the areas here in yellow and red, are activated, which means that our brain strongly engage with the task because it's important for us to respond to environmental stimuli as quickly as we can. So we need to pay a lot of attention in order to do that. Now, we have done this Oddball task in head down bed rest, and what we found is that participants were much slower in responding to stimuli when they were in the head down bed rest condition compared to when they were upright. And similarly, the same result was present when we simulate different G load using virtual reality. So on one side, in terms of sensory motor processes, I show you here that there is an analgesic effect. People are feeling less pain when they are in a ultragravity condition. On the other side, they also are slower in responding to environmental stimuli. Now, what about high-level cognition? We also focus on high-level cognition in these lab studies. And we have shown quite recently that there is an impairment in decision-making. So we ask participants to perform a task in which they need to be as random as possible. They need to generate novel behavior. Again, this is an implicit task. They need to generate sequence of numbers and try to be as random as possible. However, when they were in the head down bed rest condition, the randomness was not really there, and they preferred to go for routine, stereotype type of behavior. And of course, this is not the right strategy for the task, but they did prefer to stick to one type of behavior rather than engage in novel behavior. So the decision-making overall was significantly suboptimal. And when we look at whether not only decision-making is affected by altered gravity, but also the willingness to take risk, we surprisingly found that people in head-down bed rest were much more happy to engage with the risk. So again, we used an implicit task, which is pretty famous in experimental psychology and cognitive neuroscience, in which you ask participants to decide whether, okay, so let me explain you a little bit more the task. So you have participants in front of a screen, and then every trial is a kind of balloon that they need to pump. So every time that they pump this balloon, they can gain some money. And they can do that for several times, but randomly, completely randomly and completely unpredictable, the balloon can just explode and they won't get any money. So there's no way to predict that. You might win some money or no money at all because the balloon explodes. Now, this is an implicit task, and we can then look at the number of pumps and see what is the tendency of our participant in terms of taking risks. And when we have done this task, we found that the number of pumps, so the willingness to take risk, was significantly higher in head down bed rest compared to upright control condition. So to sum up this part of my talk, we have shown that there is a suboptimal decision making, but also an increase in risk-taking behavior. So in conclusion, I think it's important to keep in mind to look into the brain and behavior when we are planning long-term space flight as well as commercial space flight. Behavioral adaptation is crucial in order to ensure the success of these missions. So it's not trivial to shift from one gravity model to a different gravity model, whether it is the ISS 0G, whether it is the lunar, or whether it is the Martian gravity. So we need to keep in mind that it takes time and effort for our brain to adjust to this different gravity environment. It's not automatic. and it cannot be really neglected. And in particular, it cannot really be neglected when you also put into the equation the delay in communication. So it's even more important to ensure that there is support for our brain when there is a long delay in communication with ground control. Now, we have done quite recently a review of the published literature on the effect of spaceflight on brain and behavior. And we have identified 3 clusters that seems to be mainly affected by Ultragravity: the sensory motor, the cognitive, and social affective cluster. Now, when we have looked at the effect size of the effects of these behavioral changes, we found that the effect size was much higher for the sensory motor cluster compared to the cognitive and the social affective. So to say that in other words, this means that the functions that get affected much more are the ones related to sensory motor processing rather than cognition and social affective aspects. So it's even more important to support the brain in order to ensure a good sensory motor control, a good vestibular processing, a good vestibular sensory integration, in order to then prevent cognitive and social affective issues. So I hope that I convinced you that gravity is not just a simple sensory signal. It's a very peculiar one. It does not produce a conscious sensation such as all the other sensory modalities. It's completely different compared to vision, touch, or auditory. We cannot really perceive it, but it's there. Actually, it's always there, and our brain is always receiving gravitational information via the vestibular organs, and it cannot just be treated as a background signal. Gravity and the vestibular system are completely different compared to the other sensory modality. The vestibular system is fully myelinated at birth, and also is fully functional even before birth, which seems to suggest to me that can be an absolute reference for human brain and for human behavior and cognition. Now, to conclude, I think it's important to think about how to ensure long-term space flight as well as commercial space flight, how to ensure the success of these new venues. And I think there are 2 main components. The first one is the flight preparation. We need to develop fast, effective training to support our brain, as well as we need to develop some support during in-flight. Now, we have developed over the past year support for all the other physiological aspects, bones, muscles, exercise training. So probably we should come up with something that is also supporting our brain. And on that note, I would like to thank you very much for the attention. And of course, I'm going to thank you, the people here in my lab, Maria Gallagher, Ikra Shad, and Gabriele De Maio, who did the experimental work. And thank you so much.
Thank you very much for that talk, Dr. Ferro. That really gave me a lot to think about in terms of all the types of adaptations I didn't even consider that we'd have to kind of account for in space. It's really quite interesting work. Thank you.
Thank you.
So to pass on to our next guest, I will be hearing from Dr. Li Shantou, who is an assistant professor at the Division of Pharmacy, Practice and Policy. Prior to her appointment at the division, she worked as a lecturer in medicines management at the University of Tasmania in Australia. Li Xian obtained her PhD from the University of Nottingham, and she has worked as a pharmacist in various areas, which include tertiary hospital, general practice, and community. Her Master of Pharmacy was completed at the University of Strathclyde, UK. So without further ado, Dr. Li, I'll give you the floor.
Right, okay, so I'm gonna share my screen. So I trust people can hear me and see my screen.
We can hear you, but I can't quite see your screen yet, no.
Oh.
Yeah, oh, there we go. Yeah,
okay.
It's working.
Right, so hello everybody. My name is Li Shen, and as you know, I'm from the University of Nottingham, and today we're going to talk about astropharmacy and pharmacological countermeasures. I thought a brief introduction or a less formal one would be a little bit interesting. So I'm from Malaysia, and my background is a pharmacist. I started my career as a pediatrics leukemia pharmacist, and then working at a general practice-based pharmacy with remote rural areas, so with Aboriginal patients in Malaysia. I then went on to do my PhD and then got a job in Australia. And just to keep things a little bit lighthearted, I thought I'd show my favorite Aussie animal, which is a wombat on the right. I like it because it's basically a giant huggable hamster. The reason why I'm highlighting this is I just want to send the message that you don't have to be in the space sector to contribute to the space sector. So you can do it. There are challenges, but you know, we should be contributing to the space sector even though you're not there all the time. My research expertise are in improving medicines management as well as healthcare services. I typically started in osteoporosis, which we will talk a little bit more later. I also apply my research skills into COVID-19 related discriminations. And the reason why I'm here is, of course, because of astropharmacy. So we're going to go for a very quick overview of some of the health problems in space, the medications that are used in space, the types of space travelers, and the current astropharmacy research that I'm working on, as well as the other research that I'm working on and my other colleagues and team members are working on. And also we're going to talk about the future and benefit of working in this area. So Tyus has gone quite in depth into this, and so I won't do the same. But this is quite a typical picture of looking into the health problems in space. And you can see that Astronaut has a lot of pop-outs over there. So it means that you can see that almost the whole body is affected, from your eyes to your bones, to your muscles, to your immune system, to your kidney. And so when all your physiology is having some changes, you would expect that the medications that work on them would have a different effect. So because my interest is in osteoporosis, I will give a little bit more information about osteoporosis. So astronauts, when they experience weightlessness, as Tyus has said, there is a risk of losing bone mineral density. And so osteoporosis is a disease where your bones become thinner and then it's easily broken. To give you a visualization of this is if a little old lady on Earth has very severe osteoporosis, she can sneeze and she can break her back. So that's severe untreated osteoporosis. And the comparison of that, as Tyus has said, astronauts lose a bone mineral density of 1 to 2% per month. And to compare that to Earth, little old man and little old lady loses 1% about, depending on where, 1% per year. So that's astronauts are losing bone mineral density almost more than 10 times than the elderly on Earth. So what they have done is they have done some rehabilitation exercises on the ISS, and they've also tried medications. And the medication of choice that they used was what we call a biphosphonate. There are many different kinds, but the one that they use is electronic acid, and it works by slowing down the rate the bone is broken down in your body. So as a pharmacist, this is one of the drugs that has a lot of side effects and counseling points that you need to tell the patient. So when the astronauts, or that little study that we have, there were 2 out of 9 of the astronauts who got tummy problems, or the stomach didn't really like this drug. And as a pharmacist, this is something that is quite common in patients. And so we have a lot of advisory notes to take. For example, this medication is already different. It is taken once a week, not once a day or twice a day like most medications. So this one is taken once weekly with an empty stomach with a glass full of water, and you need to stand or sit upright for more than 30 minutes. And all this guideline is to try to reduce that risk of any tummy problems. So, and 2 of the astronauts got that. And the osteoporosis management has progressed since they tried this. So since then, there has been denosumab and teriparatide, which can be given as an intramuscular injection. So there are alternatives that we could try, but we just haven't tried them yet. So that's an example of a medication used in space. So we've looked into the kind of health problems in space. One of the kinds of medications that we use in space, but then now we need to think about how they are used and how they perform in a space flight. And to do that, we need to collect data. So this study collected data. It was cut short, it was stopped preliminary, but even so, they managed to find out that there was under-reporting of how medications were used and how the astronauts perceive whether they were effective or not. So we have a real lack of records of what medication was used. Understandably, there is confidentiality and things like that, but in order to do any meaningful analysis, we do need the data. So the reasons that the authors thought might be the reason for not being comprehensively monitored was due to crew time demand. It's an onerous task. Crew are able to take medications without discussing with their flight surgeon. Over-the-counter medicines like aspirin or Panadols, they can take it without discussing with their doctor, and there's no need to record. I mean, if you take aspirin or paracetamol, you wouldn't tell your doctor anyway. So there is really poor documentation, and understandably back then, we could resupply quite easily. So they resupply every 6 months, or if it's a real emergency, the astronaut can come back down. But these are something that we cannot, the luxuries, we don't have this anymore when we're going further away, say to Mars. And to make things a little bit more interesting, we don't really know how medications are used. We know our physiology changed. We know that we use a lot of medications, but we don't quite understand how the medications functions in space. So for medicines use, we have two things that we always think about. The first is pharmacokinetics, and pharmacokinetics is what the body does to the drug. And there are four main processes in that. So the first is how the drug is absorbed, how it's distributed, how it's metabolized, and how it is eliminated. So there are four processes with what the body does to the drug that we need to think about. And with the physiology changes, you would think that they might change, but we don't have much studies and evidence around that because of the small sample size and things like that. The second thing that we think about when we look about drug function is pharmacodynamics. So that's with a D. So pharmacodynamics is how the drug acts on the body. So we have an example of a study here where they look at paracetamol absorption. And so they found that on day 2 of flight, the paracetamol absorption is increased, and then it goes back to normal on the 4th day. So paracetamol is one of those drugs that we have a huge therapeutic window. So this means that if the absorption fluctuates, it's quite okay. If it's a bit too, it fluctuates, it doesn't become toxic, it doesn't become ineffective. But what if we had a more sensitive drug with a narrow therapeutic index, like a blood clotting drug? So a little bit of fluctuation would mean that you cannot clot and you would die from bleeding. If it's too little, it's not effective. You clot and you might get a heart attack or a stroke eventually. So we really need more understanding of how pharmacokinetics and pharmacodynamics of a drug works in space. It is also very difficult to predict because it's subject dependent. And now we look at the different types of space travelers. So as mentioned, astronauts are typically fit, trained, and healthy. And then we have the dawn of the space flights now, getting more common by space tourists. We also have potential for commercial workers to go up into space to do mining and things like that, hopefully in the future. And these people who will have more population, more of the humans will have access to space travel, and they could have a cocktail of medications or a variety of comorbidities and medications that have not been used in space. We don't know how they would react to the different kinds of health circumstances. So the era of civilian spaceflight has begun again, but astropharmacy is also just beginning, and it is really, really in its infancy. So that brings us to the current research that I'm working on, which is a pharmacy practice and policy science type of research. I wanted to understand what the pharmacy sector could contribute to the space sector and what the space sector needed from the pharmacy profession. So we explored what these two parties think and to ask what they think the role of the astropharmacist could be. So astropharmacy is defined as a field on how pioneers and explorers are to receive effective medical and pharmaceutical care. So the research methods are qualitative research, and it's grounded very much in social science. So it's quite different from laboratory research or quantitative research where you deal with numbers. And I'm quite a big fan of this type of research simply because society is not run by robots and numbers, and they are run by people. So I think that what people say is very, very important, and it should really be much more collaborative in scientific fields to hear what social research can contribute. It's quite often used for policy and exploratory type of studies like this. And our research methods are where we individually interview participants, or we conduct focus group with different participants. We then transcribe them verbatim. So we transcribe them word for word because our data are not numbers. Our data are the words spoken by our participants. We then analyze it with thematic analysis rather than statistical analysis. So what we do is we become familiar with the large amount of data we got. We generate codes and themes, we review them, we define them, and then we discuss and we write them out as we would for other researchers. So our sample was to ask pharmacy and space sector. So we got 53 participants. It seems very little, but for a social science research, 53 is a lot. And we managed to recruit from North America, Europe, Asia, Africa, and Australia. We also had a variety of people from pharmacy, from hospital, community, industry, policymakers, even future pharmacists. From the space sector, we have space agency leads, private astronauts, commercial companies, future space tourists, space journalism, and all sorts, just to see what is really needed from that industry. So this is just a snippet of the results. There is a whole ton more, but quite a number of the participants were very keen to see medicines being managed better in space. So medicines management are activities which promote safe and effective medication use, and it occurs at each stage of the medicine's journey, aiming to improve the patient outcome. And so medication journey starts at manufacturing and marketing, to procurement, to selection, to prescribing, make sure the legal processes are done properly, to dispensing, ensuring you take the right medicine, sale, supply, transportation, storage, even patient use. So are they taking it consistently? Are they double dosing? And also the disposal. So back then, space travel is just a small amount of people, and there was a small amount of healthcare professionals and pharmacists working on it. They probably did it very well. But now that we're looking at deep space exploration, there are different challenges, and with space tourism, there is a different amount of people with a different amount of medication, and there'll be an increased number of people. As we know, we've seen a 90-year-old go up to space. We see someone with a prosthetic leg go out in space. So there is different kinds of things. And this is an example of a data. So this is one of our participants saying that a pharmacist should be able to review the medication regimen, because what we are really concerned is, do the space travelers' current medication regimen work in the context of being in space? Someone needs to be able to understand the pharmacokinetics and the pharmacodynamics of these medications going up in space. This is another quote from a participant. So this was someone working in the space agency, and they were talking about having a refrigerator in space. So as a pharmacist, having a refrigerator for medication is a common thing, but due to the space station not having enough power, not having enough transport, you can't, or it was a difficult conversation to have to talk about medications, having a refrigerator just for medications. The engineers and the project managers did not quite understand why the medication couldn't be put together with the food fridge. And the reason for that is because you open and close it quite a lot, so the temperature fluctuates. Your expiry would probably be a bit weird, or you could get contamination from food and things like that. So these are just some of the data, and we hope that several papers will come out from it, so stay tuned. So part of the work that we have done has informed the European Space Agency space science roadmap. It was quite an achievement, and I'm very excited to say that pharmacological countermeasures for the first time was a standalone team in this type of roadmap. And so we identified from literature, expert talks, as well as from the data that I collected, 4 main areas that need more work. Whether it could be using AI, I think that's a very big possibility. Big data, I think we do need the big data, and we do need to look after confidentiality to look how medicines are recorded and used. But the 4 main areas that needs to be researched is, number 1, effects of space-altered physiology. So we've looked at paracetamol, PKPD, which is pharmacokinetics and pharmacodynamics. We don't have enough information about that. We also want to mitigate medications-related problems. So how is medicines used? How is the patient behavior with the medicines on space? Do they feel, is it effective? Are there mitigating factors? We need new systems. Maybe robots can help us identify and prevent errors. We also need to think about supply, maybe manufacturing technology to manufacture medications on site, on demand. We also need to cope with emerging hazards. We don't know what mass planetary hazards there are. We don't know much about deep space radiation. How could it affect the storage? We also need to optimize our existing medications. So for example, we looked at osteoporosis. They use biphosphonates, but since then the management has progressed. So we need to update the management as per new terrestrial treatment. And pharmacodynamics, which is personalized medication, is also an upcoming hot topic on how to use medicines in space better. And these are my other research and fellow researchers. So we have an analog space research mission that would be the first in the UK, and it is in spring. So let's see how that goes. That's very exciting. We also have people looking into osteoporosis medications in bed rest studies. We have people sending satellites up. We have people looking into technology on how to manufacture on-site, on-demand of medications. We also have people sending up worms to look at muscles. We have some bed rest studies on that as well. We also have scientists looking at food science, and we also have a collaborator in Australia. So he's looking at the expiry of excipients in the ISS, and his payload just came down on the 1st of October. So we're very much looking forward to see what that result will say. So we came all this way to explore the moon, and the most important thing is that we discovered the Earth, which is what William Anders said. I know that a lot of money is being spent on the space sector, but it's important to know that things like the GPS came out from space tech. So you never know what you develop to help the space sector could help other extreme environments like Antarctica, submarines, disaster area, or even just your daily lives. So come help forge the advancements of human space flight. It doesn't mean that I talk about pharmacy, you can only work in pharmacy. My team comprised of psychologists and biomedicine and engineers. So, you could be the world's first, whatever you want to be. So you are the future. We really need to answer this medications question so that humans can have a sustained presence in space and can be that interplanetary species that we want humans to be. So just a shout out, thank you to people who supported me, like Phil Williams, Claire, Virginia Wotring, Luke Sawyers, Laura Beckett, so all the people who supported me, scientists, academics, students, and the UK Space Agency and the European Space Agency for funding me and standing behind my back with my crazy ideas. So my email is on the bottom right if you ever want to contact me. Thank you.
Thank you, Dr. Lee, for that great talk. Very interesting. Thank you very much. I'll leave you take your screen off. Is that, there you go, cool.
Yeah.
Thank you. So our next guest, so we're supposed to have Dimitri Kaminsky, who is the general partner of a Deep Knowledge Group, come in and talk now, but he was unfortunately not able to make it. So instead, we have another representative from the Deep Knowledge Group who goes by the name of Dimitri as well, but Dimitri Karchenko, and he is the head of InvestTech and Space Tech Analytics. So Dimitri, I'll pass over to you.
Yeah, hi everyone. First of all, I want to thank you everybody for attending here. Thank you speakers, thank you attendees. So I would like to share my presentation about longevity in space medicine, practical implication to establish the mindset of space as the next longevity frontier. Well, there is our table of contents, so we will first move according to this. First of all, I want to say some words about space tech market at all. We as Space Tech Analytics discovered this market very deep and create a huge amount of information with 12,000 companies, 5,000 investors, hubs and R&D centers, and government organizations. There is a bigger market that we thought, and we estimated as at $4.67 trillion and expected to grow to $10 trillion in 2030. Why so big amount? Because we added to space tech industry also with satellite technologies and space explorations, also IT part, which helps satellites and other companies to create more and more and more. Digital technologies, which allows to create more added value here, and fintech, which allow to gather all the funding to create new startups, to develop many markets and to discover more projects. Also, public sector is expected to grow too. Well, actually, NASA launched the crewed flight to the International Space Station, commercially developed US rockets. So we expect that these projects, such projects, will continue to complete and to discover more of them. About company distribution, that is quite simple. North America is the leader of the industry with more than 6,000 companies. It contains more than 60% of the market. And as we see during the commercializing the market, the number of companies that exist in each year is increasing. Yeah, the second huge player is Europe and Central Asia. Next is Asia, East Asia, and Pacific. Then let's figure out the space medicine market, which we define as the combination of research equipment, biotech, bioengineering, and also longevity, telemedicine, and research design, which has 35%, 25, and less than 5%. Let's go to the key space medicine achievements. I think most of you know about Yuri Gagarin as the first astronaut, as the Hubertus Struholt as the creator of term space medicine in 1931, NASA Gemini program, Scale-up program, and so on and so on. And there is huge achievements which led us to the 2021. Despite that, spaceflight presents formidable challenges. Weightless, partial gravity, planetary dust, and space radiation pose a significant threat to humans in both spaceflights and living a planetary habitat, resulting in a rapid development of life-threatening diseases in astronauts. In addition, the closed environment can create additional stress on the space crew work performance and mental well-being. And next challenges for the space tech industry and especially space medicine, is to figure out how to solve these challenges. But despite that, we have a growing interest in private rounds of investments, especially NASA made several contracts with private companies, and now 55% of all American space tech market contains private companies. Similar contracts were made by China, by European Union, and less with Russia. Also, one of the good tendency is increasing the money spending per each contract. As you see, in 1921, the cost of the prices were rising significantly, which allows small companies to perform their solutions and to create more value for that, not for the big players. Here you have you can see the main companies, the top companies in different countries in US, Israel. I want to point out the Biogen Inc., MicroQueen, Amgen, and Encode in US as the big players, Space Pharma and Sanofi from Israel and France respectively, and AstraZeneca, which increased the budgets for the space connected projects. Also here you have a timeline of private biological research on the International Space Station, which is a really huge amount, and private age-related research in space. Is 35% of all private researchers on IS is dedicated to drug delivery assistance to conquer cancer. We will speak about that a bit later. And also, as an example of coming era of private habitable space facilities, I want to present Exion, which is NASA awarded company with 140 million contract. Thales Athena Space, a joint venture between Thales and Leonardo, and launch a large integrated flexible environment habitat. Well, there is very big industry, but we need to figure out our challenges for health in space. As you've seen from previous speakers, the main problem of inhabiting in space, there is changes of physiological state of the astronaut. Most of the problems deal with sensomotorical deficit, with learned paraspinal muscle volume, with lower limb bone loss, and changes in microbiome taxa. And to change this, we need to figure out how to recover our astronauts and get back to the normal state after the flights. And also one of the biggest challenges is the cardiovascular diseases, which possibility of arrival during the long-term flights increasing rapidly to more than 30%. And I want to present the difference between short-term and long-term space flights, because when we see the consequences of short-term space flights, there are muscle loss, bone loss, and renal dysfunction. In contrary with that, long-term space flights got more significant losses during the neurological disorders, cardiovascular disorders, which arrival can be increased rapidly. Well, and also one big challenge is mitochondrial change. I want to point out the twin brother case from NASA, which allows to see the differences between the just Earth inhabitant and astronaut, which are twin brothers, and to see the difference between the settling here and to live in astronauts. As you see on the biomarker level, the changes are significant and are close to the aging of person. That's why we want to combine our knowledges in space activity and aging activity. As you see, the main, as you see, 5 important mitochondrial biomarkers such as SOD, BCL2, LDH, complex 1 and complex 2 have same changes in astronauts after space flights and aging too. So we can assume that these processes are similar. And one important issue is the mitochondrial respiration, which is decreasing during the flight, and increasing of membrane lipid peroxidation during the aging and living in space too. Well, to figure out more, you can go to the to our report combined together with the Age Analytics Agency, which is called Mitochondria in Longevity and Space Medicine, to see more about it. So how can we make countermeasures for long-term space flight associated disorders? There is a big amount of issues. So selecting fittest individuals, which is too simple: hibernation, gene therapy, protection drugs, P4 medicine, cell therapy, biomarkers, longevity, neurotech, and so on and so on and so on. There's a big amount of issues. One of the important countermeasures of that is radioprotectors, which are capable to reduce damage caused by space radiation and increase astronauts' resistance to radiation exposure. Having a formidable potential, they are extremely important in the era of space exploration, development, and settlement. And what is good is that the amount of researches into radioprotector sphere is increasing during the 21st century. And we believe that the next turning point will be on radioprotectors. Which is quite simple, but exercises help to solve some difficulties, some challenges during the in-flight inhabiting, like active fitness, exercises which increases the amount of plasma in the body, blood volume, and so on and so on. And also the important part is bioregenerating life support systems, which are considered the most advanced systems to provide space crew with oxygen, water, food, and clean up the air in the space. The development of such technologies will help to decrease the influence of the in-flight solutions. And the next one is the intermittent hypoxia training. Made in the second part of the 20th century, there is the that is the technology which allows to train astronauts with hypoxia, with less amount of oxygen, and is widely used to practice for military and civilian pilots that allow them to recognize their early hypoxia signs and symptoms, and to work more productive and to decrease the problems with vascular diseases. More you can write about this hyperoxic paradox in such articles. And also, I want to point out the technology-driven solutions for Earth-based, because as I told, the longevity sphere and the space sphere are connected, and different devices made just for just for using in space tech industry is also useful in our Earth life, especially extraterrestrial organs for terrestrial needs, drug development, next generation wearables, diagnostics with remotest patients, and analyzing labs. And one important implementation of space health technologies is biomonitor technology developed by Canadian Space Agency, aiming to carry out the comprehensive analysis of astronaut condition, including skin temperature, activity level, and so on and so on and so on. So I want to point out key trends. We need to understand that Earth is a celestial body. The origin of all space medicine strategies come from Earth, because we are from Earth, and we need to remain the same as possible in this space as the biological species from Earth. Longevity medicine is closely aligned with space medicine, as we reasoned before. We need to figure out that we need to adapt the space environment to human body for initial settlements, not the human species to space environment, because that is unfortunately impossible. AI, genetic engineering, and quantum computing will revolutionize the medicine. We think that there is a future of the development of space medicine and space tech at all. And we need to use robotics to augment 99% of human presence requirements. To find more information, we suggest you to read books from our general partner Dimitri Kaminsky. For example, Longevity Industry 1.0, and a new upcoming book, Biomarkers of Human Longevity, which will be presented on our upcoming conference, Biomarkers of Human Longevity, State of the Market and Diversity of Practical Applications. So we invite all of you to that conference. That will be really exciting. And here on the book, for example, Dimitri explained the connection between space tech, space medicine, and longevity industry. And more you can listen on the upcoming conference. And more about the space medicine, you can read here on such articles from Space Tech, Space Tech Analytics. So just visit spacetech.global to learn more about it. And to find interesting companies for the investment, you can find on the dashboards, which are made on spacetech.global dashboards. So, and figure out more about DKG. So thank you. You can contact us, and if you have any questions, just ask. Thank you.
Cheers. Thank you very much, Dimitri. Okay, so for our penultimate guest, we have Dr. Scott Solomon joining us. So Dr. Solomon is an associate teaching professor in the Department of Biosciences at Rice University and the author of Future Humans: Inside the Science of Our Continuing Evolution, published by the Yale University Press. So he is a writer / producer / scientific consultant for Becoming Martian, a Curiosity Stream show, and a professor with Wondrium / the Great Courses and the Glasscock School of Continuing Studies. He's also a research collaborator at the Smithsonian Institute National Museum of Natural History and the host of educational travel adventures in wild places. So Dr. Stott, if you can hear me, I'll pass over to you.
Yes, there we are. Okay, I can hear you. Can you hear me okay?
Yeah, it's all good. Thank you very much.
Wonderful. Well, thank you very much for the invitation to participate in this conference. I think it's a very interesting topic, of course, and one of the things that I want to convey in my remarks today is how important I think it is that people from different disciplines come together to discuss the human future in space. I myself am an evolutionary biologist by training. I teach courses at Rice University in Houston, Texas, in ecology and evolutionary biology. And my research is on the ecology and evolution of ants. And for the last 12 years or so, I've become very interested in the possible evolution of humans in space if we are to establish long-term settlements beyond Earth. And so what I want to emphasize today is that I strongly believe that in order for us to be successful in establishing human settlements in space in the long term, we need to draw on research from a wide range of different disciplines. The emphasis on medicine here, I think, is very important. Obviously, safety is first and foremost priority for any human exploration and time and space. But of course, my background as an evolutionary biologist causes me to think very long term into the deep future. And that has caused me to draw on research from disciplines ranging from genetics to anthropology, sociology, psychology, microbiology, medicine, physiology, and others. And it's great anytime there's opportunities for people from different disciplines to come together and talk about what we know, what we don't know, where we would like to see the research moving forward. So what I want to do today is to talk about what to me seem like 5 of the most pressing questions that we really need to be addressing if our hope is to be able to successfully establish human settlements in space. So clearly, I probably don't have to convince this audience that the notion of human settlements in space is something interesting and important. I think we're all aware that efforts are underway to try to create human settlements in space. Some of those are human settlements that would be a short-term presence, a base on the moon, for example, that would have people going and spending some amount of time there, weeks, months, years, but ultimately returning to Earth. My talk will focus more on the possibility of long-term human settlements in space, settlements that would involve people spending their entire lives there and reproducing. And that's where I think we still have a long ways to go before we're ready to do that, but we need to be thinking about what steps should be taken in order to get there. So the first question I want to address is, how many people do we need for such a settlement? What is the population size that would be necessary for a long-term human settlement to be successful? And this is a question that, again, you can approach from many different disciplines. One way that I've tried to approach thinking about this question draws on my background as an evolutionary biologist, because in many ways, settling space is very reminiscent of the process that happens on Earth all the time when some type of species goes and colonizes a new habitat. That could be an island that pops up out of the sea, or it could be a patch of forest when a tree falls that becomes cleared and organisms are able to move in that weren't able to live in the intact forest before. Basically, anytime that there's a opportunity for individuals that weren't there to go and establish a new population, we get something that is similar to the process that we're thinking about in terms of settling a new place in space. And so we've learned quite a lot in evolutionary biology about the population size that is necessary for such a population to become established and successful? And what are the consequences of having a population size that's too small? So there's actually a phenomenon in evolutionary biology called the founder effect. And the founder effect is essentially the effect of having founding members of the population. It's the long-term effect on that population of the number and identity of those founders. And in essence, what the founder effect shows us is that the smaller the number of individuals, the less likely that population is to be successful, which is not a surprising conclusion. But it also tells us that when a population size that is founding a new settlement is small, that those individuals that establish that new population, they have a disproportionate effect on the identity, on the characteristics of the population that will become established later. So, one of the examples of this is how, whatever those individuals are, whatever traits they have, well, those are the traits that are likely to be, common in subsequent generations of that population. And it's unlikely that those individuals that we were talking about, a small number of individuals drawn from a larger population, it's unlikely that those small number of individuals are representative of the entire larger group that they came from. And because of that, the new population is likely to be different from the larger group from which they were drawn. And so the founder effect shows us that anytime a small number of individuals establishes a new settlement, that it is very likely that that new population will be different from the population from which it came. And the smaller that group is, the more likely they are to be different. But there's a second point to the founder effect, and that is that the smaller the number of founding individuals, the less genetic diversity there is going to be in the population, even if it is successful. So not only because there's a small number of individuals, but when you have small numbers of individuals, you get a phenomenon known as genetic drift, which is actually an evolutionary process by which the number of how common a particular trait is in a population fluctuates randomly. It could randomly become more common, or it could randomly become less common. And it's much more likely that it becomes randomly less common to the point that it disappears. When traits disappear, it reduces the genetic diversity of the population. So founder effects are tightly correlated with having low genetic diversity. And that leads me to my second key question. And that is, how should we be choosing the individuals that would establish a human settlement beyond Earth? And I think that we really will be forced to go back to the drawing board, so to speak, when it comes to how we select individuals for space travel, because so far, space organizations like NASA, ESA, and others, they primarily have chosen individuals who are very physically fit, very mentally fit, of course, very capable of doing work under stressful situations. They tend to be adults within a fairly narrow age range, who have had already a lot of experience in doing relevant types of challenging work. And that makes a lot of sense for the type of work that has taken place in space travel up until now. But if the goal is to establish human settlements, then I think we really will need to revisit those criteria. And specifically, it will become very important to try to create a very diverse group of settlers. And I mean diverse in many different forms. Diversity, of course, can mean many different things. And so I think what we need to clarify here is that the component of genetic diversity is going to be absolutely essential for the success of a future colony. Why? Because what evolutionary biology shows us is that populations that are more genetically diverse are more stable and more resilient, meaning that they're more likely to be able to survive through challenging times and stressful conditions. Also, genetically diverse populations are better able to adapt to changing conditions. And as we'll see, that's going to be essential for long-term success of a human settlement beyond Earth. So we'll need to be thinking not only about people who are going to be able to, tolerate the trip and bring important skills to the work that needs to be done. Obviously, those will still be important as they are now, but we also need to think about the genetic diversity of those individuals. I think an argument could be made for, trying to intentionally select from all of the genetic diversity of the human species, which is something that, to date, we really have not done when it comes to astronaut selection, cosmonaut selection. So I think this is going to be a complete pivot when it comes to how participants are selected. Now, as I said, my focus here is on long-term human settlements. And if the goal is to create a self-sustaining human settlement, then by definition, we will be requiring human reproduction. And this brings us to one of the most fundamental questions, which is human reproduction beyond Earth possible? If it is possible, what are the effects of the conditions that people would be exposed to? And what are the challenges that would come with human reproduction? I'd like to break this down into three different, separate but related processes or steps. The first being fertilization. Is a fertilization of a human embryo possible? Are there consequences of the environment of space that could be problematic? The second being pregnancy, and the third being childbirth itself. And so this is where it's quite interesting that we have some research that has been done on this. There have been studies in low Earth orbit and simulated microgravity that have included organisms ranging from sea urchins to some species of fish, some amphibians like salamanders and frogs, some birds like chickens, as well as some rodents, mice and rats. And the conclusion from the weight of the evidence in these studies is that we really don't know what the outcome would be for human reproduction. It seems that each of these steps is possible, but there have been studies that have found some problems that have popped up for each of those steps. So from fertilization through implantation and pregnancy, very little on childbirth itself. And of course, we have to extrapolate from these animal models to a human system. So this is an area that I think if our goal is to create long-term human settlements beyond Earth, we really need to have much more research in space conditions in low Earth orbit or in simulated microgravity that can help us to understand what will be the challenges of each of these steps in human reproduction: fertilization, pregnancy, and childbirth. And a related question, but I think one that is worthwhile separating, is what happens after a child is born? How is child development affected by the conditions beyond Earth? So far, I haven't really specified where I'm talking about. When I say beyond Earth, this could be in low Earth orbit in a space station. This could be on the moon. This could be on Mars. This could be elsewhere. But of course, as we know, the conditions have some similarities in that the gravity environment is likely to be different from Earth gravity, likelihood of enhanced or increased radiation exposure, and other situations. So we can start to draw some parallels between the work that's been done, for example, on low Earth orbit to what the situation might be like on the surface of Mars. So I specifically highlight child development because we know what the effects are of low gravity on an adult human. We know that muscles begin to atrophy, that bone density decreases, and demineralization of the skeleton occurs. We know that that can be counteracted to a certain extent through exercise and resistance exercises. But of course, these still remain challenges for people that spend even short amounts of time in low Earth orbit. So the big question to me is, what would be the outcome for a child, a growing human who needs to develop a skeleton that is going to be functional for the conditions, not only where that person is, but also if they are going to be traveling elsewhere, such as coming back to Earth. And so I think we need to better understand what the effects would be of microgravity on a growing child's body. Related to that is a question about the microbiome, something that I think we often don't think as much about when it comes to space travel and some of the challenges that we'll face. But we've learned quite a bit in the last decade or two about the importance of the microorganisms that live in and on the human body. In fact, we know now that we cannot live without these microorganisms. And yet we acquire these microorganisms from our environment after we are born. And many of them we get from the people around us, including from our mother through the birth process, as well as from parents, siblings, close playmates, et cetera. And much of that establishment of the microbiome happens very early in infancy and childhood. And it's almost certainly the case that moving beyond Earth would result in at the very least, a change in the types of microbes that we're exposed to that are able to inhabit the body and form the microbiome. And most certainly a reduction of diversity in the types of microorganisms. Interestingly, that reduction in diversity parallels what we have seen as human civilization has advanced. If we look back at the microbiomes of people living 10,000 or more years ago, we see they had a much greater diversity in their microbiomes than most people do living today. Some people have suggested that reduction in microbial diversity has could possibly explain the rise of certain, for example, autoimmune disorders and other conditions that have become more prevalent in recent years. We don't know if that's the case, but if we're going to be talking about a drastic reduction in the diversity of microbes that can possibly inhabit the human body in space, we need to have a much better understanding of what the consequences would be of doing that. And for the fifth and final question, we need to really understand more about how adaptation to conditions beyond Earth would affect the ability of people to be able to return to the Earth. I've already alluded to this in my comments about what might happen to the musculoskeletal system. It seems possible that if a child is born, for example, on Mars and is exposed to the 3/8 gravity of Mars, that their skeletal system would be weakened to the point where leaving Mars and returning to Earth and experiencing not only the re-entry to the Earth's atmosphere, but also the 1G environment here on Earth might simply be too much for that person's body to be able to tolerate. Going back to the notion of the microbiome and the importance of the microbiome, I think we have to think about this in the same context, because it's possible that by not being exposed to the diversity of microorganisms that we normally are here on Earth, and almost certainly not being exposed to many of the same types of pathogens, infectious disease agents as we are here on Earth, that the immune system of people living beyond Earth could be compromised or weakened, or perhaps over generations even atrophy, to the point where returning to Earth could be extremely dangerous, if only because the people would not be able to tolerate the types of even common microorganisms that we have here on Earth, and something like the common cold could end up being, a lethal threat. So I also want to make a distinction here between the difference between acclimatization and adaptation. So what I mean by adaptation here is really the way we use it in evolutionary biology, which is change over multiple generations. And so in that sense, with each new generation, we would expect that the individuals living beyond Earth would become better and better adapted to the local conditions, the conditions, for example, on Mars, which would make them better at surviving and thriving in that environment. But with each passing generation could make them less and less fit for returning to the planet Earth. And this is something we have to really take seriously, because we need to think about what would be the consequences of creating a situation where people multiple generations from now are unable to come back and experience everything here that we love about planet Earth and their entire heritage. So I think I'll stop there. I want to thank the organizers once again for inviting me to present today, and thank everybody for your time and attention. And I look forward to an interesting discussion ahead. Thank you very much.
Thanks, Scott. Great talk. Really interesting stuff. Love it. Cool. So now it's time for our final panelist. So our final panelist is going to be Dr. John Sen. So he is a Dr. John Sen is a I've got everything. Here we go. He has a long-standing interest in the brain and in health and disease. He is an assistant professor of neuroscience at the University of Nottingham. Following his PhD in neurotrauma at the University College London, he's honorary clinical lecturer at Keele University in collaboration with the Neural Tissue Engineering Group, and assistant professor of neuroscience at the University of Nottingham. He is also a medical doctor at Mayday Assistance Limited and Hearts First Ambulance Limited. In this role, he manages patients all over the world, often in very challenging conditions, and has undertaken nearly 400 air ambulance missions worldwide. So Dr. Sen, I'll pass the floor over to you.
Thank you. Can you hear me all right?
Yep, it's all good.
Good. Well, thank you very much for the invitation to the organisers. And I'd like to echo, I think, the previous speakers who mentioned the need for a continued multidisciplinary approach. And it's exciting to be part of such a diverse panel today, exploring the same problem, but from different angles. So I'm going to be talking about the nervous system in weightless conditions. Now, as a neurosurgeon, I spend most of my time dealing with surgical problems in the cranium, and these are mostly space-occupying problems, essentially. Most neurosurgical problems are pressure-related in some shape or form, and they are dynamic-related, if you like. They're aimed at salvaging penumbral tissue, which is the tissue around any lesion which might still be salvageable. So it's about trying to maximize outcomes for patients. And I've managed and monitored many different types of brain injuries in different environments in many locations around the world. And these are often very challenging conditions. And so this, as well as an academic interest in neuropathology, has driven my interest in how we're going to approach and research what happens to the brain in zero gravity. And I think from my reading of it so far is that this is not going to be an easy task, but it might be that as a byproduct, we can learn a little bit about the brain conditions that we see on Earth in the process. But I think what I will touch on a little bit in this talk is how the extreme complexity of the brain makes it a very vulnerable organ, and that in itself poses great challenges in terms of how we might manage problems in space. So the brain complexity explains its vulnerability and slowness to recalibrate and regenerate itself after disturbance. Any very complicated structure is more likely to struggle to repair itself and necessarily take its time to repair itself because it has to get it right. The brain is, as we were hearing earlier on, very complex. It's in fact the most complex structure in the known universe, and therefore inherently difficult to study in any environment, particularly in a non-gravitational environment. We're looking at a total of about 86 billion neurons and around 86 billion glial cells, which are the supporting cells, the homeostatic regulators that supply neurons with energy. And each of the neurons connects to vast numbers of other neurons to create complex neural networks. And that creates a network of 100 to 1,000 trillion connections or synapses. And these highly complex neural networks allow it to be a very sophisticated learning and prediction machine, not really the same as a computer, because computers have very predetermined sets of inputs and outputs, whereas the brain has constantly unpredictable, non-predetermined outputs to deal with. So the brain we can think about as a biological computer that's evolved in numberless forms over many eons. In a sense, we are neuronal synaptic computers, with neurons being the bits and synapses the switches. And the operations of individual cells and cell types are now much better understood, but how they cooperate in ensembles of so many billions is really yet to be solved. And looking at the computational capacity of the brain, the neuronal synaptic computation is on quite impressive orders of magnitude. So if we have 10 to the power of 11 neurons per brain and around 10 to the power of 3 synapses per neuron operating at functionality of about 10 to the power of 2 hertz, that gives you 10 to the 16 operations per second per brain. And then if you drill down further to subneuronal activity, if you look at microtubules in the brain, for example, within neurons, and the tubulin proteins that they're made of, there are approximately 10 to the power of 9 tubulins per neuron performing operations at approximately 10 to the 7 hertz, which gives 10 to the power of 27 operations per brain per second. So it's an ultra sophisticated system. It makes it very inherently hard to repair itself when it goes wrong. Just to look at the intracranial contents, essentially the skull is a fixed box containing 3 major components: the brain parenchyma, the tissue itself, the cerebrospinal fluid, which the brain floats in and is bathed in, and the blood supply. And any shift in any one of these causes the others to reduce. So a blood clot, for example, a subdural or extradural hematoma in the brain, when it enlarges, you're going to have some extrusion of CSF. You're going to lose some of that content out of the skull. And the brain has internal homeostatic mechanisms for maintaining normal pressure, what we call normal intracranial pressure, and cerebral blood flow to prevent hypoxic ischemic tissue injury. And if there is any kind of a space-occupying lesion, whether that's blood or a tumor, whatever it is, there is a compensatory mechanism whereby blood, whether it's arterial or venous or spinal fluid or even the brain itself, is pushed out of the brain, out through the hole at the base of the skull, the foramen magnum, through vessels, or the brain itself herniates down to try to normalize the intracranial pressure and allow adequate flow of blood. But beyond a critical threshold, intracranial pressure rises and you get potential brain herniation, which is rapidly followed by death. And this mechanism for maintaining intracranial pressure is known as the Monroe-Kelly doctrine or hypothesis. So because of limited space in the skull, increase in any one of the components necessitates a change in volume of the other. And there is a compensation to maintain a normal intracranial pressure of 10 to 20 millimeters of mercury, and that's accompanied by the displacement of any component. Increased intracranial pressure with disease or injury leads to a reduction in cerebral perfusion because of that increased tension and pressure in the brain, which leads to ischemia, cell death, and then further edema in a very deleterious cycle. So the brain evolved to deal with unpredictable inputs, but it's evolved to be predicting things in a very specific gravitational environment at 1G. And at 0G force, and we've heard it mentioned earlier this evening, you have a cephalad, shift in fluid, in other words, a shift in fluids up towards the brain. And this causes altered dynamics in the spinal fluid compartments in the brain. It has effects on the pituitary gland in the anterior skull base, can cause the increased pressure of spinal fluid around the pituitary can cause deformation of the pituitary gland, which can have, we don't fully understand yet, but it potentially could have quite wide-ranging endocrine effects. And some more recent studies have shown cortical grey matter loss, so cell loss in astronauts who've been exposed to weightless environment. Vestibular system distortion, because there's no up or down in space, we've also heard a little bit about earlier, and increases in brain cortical excitability from transcranial magnetic stimulation studies is something I won't talk about, because I think there's a subject for a talk in its own right, probably. So I'm going to probably just stick with mainly with the fluid shifts and fluid dynamic problems that we're seeing. So as mentioned, there is a cephalad body fluid shift in 0G force, whereby the brain floats upwards somewhat inside the skull. On Earth, the gravitational field creates a hydrostatic gradient, a pressure of fluid that progressively increases from the head to your feet while standing or sitting. This pressure gradient isn't present in space. In 0G, fluid such as venous blood no longer pools towards the lower limbs, but it redistributes headward, and that causes a raised intracranial pressure, and you get enlargement of these CSF spaces in the brain, these lakes of fluid called the ventricles, in which spinal fluid is actually synthesized, and where it circulates. And these scans, these axial CT scans, are just to give you an example of what increased ventricular volume, increased spinal fluid volume can look like inside the brain. It causes pressure on the brain around it. And it can also cause alteration in optic nerve and pupillary pituitary anatomy, which I'll show you shortly. And these can lead potentially to multiple symptoms of visual, cognitive, and coordination type problems. These scans on the right are just to give you an idea of this black space here is what happens when you have too much spinal fluid in the brain. The ventricular size can increase quite significantly. And these are MRI scans of an astronaut. So on the left pane, A is a pre-flight baseline image, and B is the matching post-flight image at post-flight day 1 in the same astronaut. And the black arrowheads show an upward expansion of the anterior anterior, middle, and posterior superior margins of the lateral ventricle, with associated narrowing of this marginal sulcus here compared to here. And there's a subtle expansion of the third ventricle, which is shown by the number 3 here, which pushes on the thalamus above it. And the thalamus is a vital territory, because all sensory inputs to the brain pass through the thalamus. And there's also slight thickening in the soft tissue. The 3 arrows at the top on the scalp here show that the fluid is also accumulating in the scalp soft tissues as well. And these same CSF fluid shifts can cause visual problems. So just to show you the normal optic nerves on the right, here the right eye and the left eye with the optic disc at the back of the retina on each side. Well, the eye essentially, the optic nerves are surrounded by the meninges, the dural coverings of the brain. So in development, the eye grows forward from the brain and drags the dura with it. So you have CSF spaces surrounding the optic nerves. So if you have increased CSF volumes in the brain, it's going to transmit down to the eye. And here, on this axial cut through the optic nerves, you can see pathologically wide spaces around the optic nerves, showing the presence of excessive cerebrospinal fluid. So the optic nerve itself is not a true cranial nerve. It has no nucleus in the brainstem. The eye is actually a forward extension of the brain itself. So when you're looking at the eye, you're looking at the brain itself. This anatomical arrangement leads to this specific set of risks if there is any space-occupying pathology or increased spinal fluid buildup within the brain. And what is known is a condition called SANS, or spaceflight-associated neuroocular syndrome, is documented in people in astronauts exposed to weightless conditions for long periods of time. And this raised intracranial pressure appears to result from this exposure to long duration space flight, and persistent blurred vision is the primary presenting complaint. So these fluid shifts can affect the pituitary gland as well. I don't think it's really fully understood. I don't think it's been studied to any real extent. What the full range of endocrine functional effects could be from this. But what we're looking at here, so this is a sagittal image of the brain. So within this white square, that's the pituitary gland there. Here it is here, covered by a diaphragm, protected by a diaphragm with the optic nerves just above, and all the blue is the spinal fluid, and here's the brain stem here. And if there is increased CSF fluid pressure, it can push and completely deform the shape of the pituitary gland. And pituitary flattening has been seen on studies of astronauts. Brain MRI of 11 astronauts, 10 men and 1 woman before International Space Station travel. And these astronauts were followed up with MRI studies a day after the astronauts returned, and then at several intervals throughout the ensuing year. And the scans showed that weightlessness exposure in long duration spaceflight caused expansions in the astronaut's brain and CSF volumes, which are elevating intracranial pressure. The bulk of the expansion appeared to be due to enlargement of the ventricles, the lakes of spinal fluid. And at the 1 year post-flight mark, the volumes remained elevated, suggesting a permanent change in brain structure. And most of the astronauts had MRI evidence of pituitary gland deformation, suggesting a persistently elevated intracranial pressure during space flight. And in addition, the dome, the top of the pituitary gland, which is predominantly convex in astronauts without prior exposure to microgravity, showed evidence of flattening or concavity post-flight. The top panel, pre-flight and post-flight, showing A is the anterior, the pituitary gland is split into an anterior and posterior part. So the whole of this is the pituitary gland. But A is the anterior, P is the posterior, and this is an astronaut who'd not had any exposure to long duration spaceflight in the past. This astronaut had long duration spaceflight on the space station before, and is showing some flattening here of the dome of the pituitary gland, and this one is a more severe case where there is a curvature here, but it's quite flattened. And the pituitary stalk, which is this part here, which connects the pituitary to the hypothalamus, has this curvature, which is really not normal at all. So in addition to these fluid dynamic problems, there is also evidence of particularly grey matter, so the cells of the cerebral cortex. There's good evidence of loss of grey matter volume, loss of these cells with long duration space flight. A paper published in the New England Journal on 10 cosmonauts looked at MRI scans before and after time on the International Space Station, the average time being 189 days. And the MRIs showed cortical grey matter reduction mostly in the right temporal lobe. Well, that's where the maximum shrinkage was of 3.3%. It also showed increased spinal fluid volume of up to 12.9%, which is quite significant. And at 7-month post-flight scans, the grey matter was still not fully restored, and the CSF volume was still increasing. Another study by Lee et al. In 2015 looked at simulated microgravity, 18 subjects with 6 degrees of head of bed down for 30 days. And they did 3 Tesla MRI scans before and after. And this also showed grey matter volume loss, also in the frontal lobes bilaterally, and in the right and left parietal lobes as well. And grey matter loss in these territories is almost certainly going to lead, if not to overt changes, but anything on a spectrum from subtle to overt changes in performance, locomotion, cognition, coordination, learning and memory, and possibly even auditory processing as well, something which some researchers have called a space brain. Vestibular system has been touched upon earlier, so I wouldn't spend too much time on this now, but of course the ear, in the same way that the eye really is the brain itself, because it's a forward extension of the brain, the special sense of the ear as well is so intimately related that I think it was worth mentioning. And the semicircular canals and the utricle and the saccule really struggle to deal with the zero-G environment. The inner ear has evolved such that the minute crystals, the calcium carbonate crystals in the inner ear, which move on this very thin gel inside the otolith organ, this movement is completely disturbed, becomes non-physiological in a non-gravitational environment, leading to sickness, dizziness, and disorientation. So there are a whole range of different spaceflight associated stresses on the brain, and zero gravity causes this cephalic fluid shift, otolithic deprivation, and weightlessness has effects on limb unloading, hypokinesia, difficulties with mass discrimination, proprioception, problems with manual dexterity, impairment of complex motor tasks and dual tasking, for example. And there are all these other issues to deal with: radiation, isolation, confinement, circadian rhythm disruption, poor sleep quality, which can have manifold effects, and problems with blood gas control as well, whereby some astronauts have elevated CO2, and that can also have knock-on effects on intracranial pressure. As a sort of a summary slide, I just wanted to show that the visual, somatosensory, motor, and vestibular systems, and the cerebellum is the small brain at the back of the brain. In Germany, it's called the Kleinhirn, the small brain, but it has a huge role in motor coordination. It's a bit like it's a backseat driver, if you like. The cerebral cortex is the main driver and executor of motor activity, but the cerebellum is a backseat driver in that it knows what the cortex is doing or trying to do, and is constantly regulating and refining it. And all these systems work together in a highly complex, integrated fashion. And disturbances in one or the other can have major knock-on effects on the other systems. For example, the vestibular ocular reflex, if there are disturbances in the our perception of how the ear and the eye function in concert together via a part of the brainstem called the superior colliculus, which mediates this vestibular ocular reflex. If one of these goes out of sync, very crucial reflexes can be quite significantly impaired. Finally, I'm just going to mention briefly that there might be ways of monitoring these fluid shifts and these pressure changes in the brain. And some research that I've been involved in the neurocritical care environment, in some of my postdoctoral research in patients with severe traumatic brain injury and some types of stroke, mainly subarachnoid hemorrhage. We've used a device called a pupillometer, which is essentially like a small camera which you shine into the eye, and it flashes infrared light into the eye 30 times per second, and over 3 seconds it collects a lot of really useful physiological data from the pupil, and it can detect pupillary changes which are actually undetectable with the human eye. It's essentially assessing the PLR, the pupillary light reflex, which is shown. It's very complex neuroanatomy of the autonomic nervous system that controls pupillary responses to light. And this device, the pupillometer, it's a handheld device like a camera. It measures essentially the constriction velocity of the pupils. So rather than what we've conventionally done in the past, just use pen torches to say the pupil is responding or not, or it's responding a bit slowly or responding briskly, we now have the ability to actually measure the constriction velocity of the pupil. And we have developed protocols in the neurointensive care environment whereby if the bedside nursing staff are finding significant differences, for example, between the right and left eye, or they are finding that the constriction velocity is changing in a worrying direction, then they call the neurosurgeon and we might rescan the patient or implement maneuvers to try and offset whatever the problem is, to diagnose and offset the problem. And there is some evidence emerging that abnormal pupillometry values, even in mild cases of concussion, for example, in sports-related injuries, where the patient is conscious but not quite right, mild traumatic brain injury that you wouldn't see anything abnormal on a scan, but the brain has been shaken and there are metabolic disturbances going on in the cells. The pupillometer does seem to be able to pick up discrepancies between their baseline values and their concussion values, and as a result, it's possible to interpolate that pupillometry measurement as a non-invasive tool in the space environment might give us an early warning detection system for changes in the brain that we might then be able to implement management techniques at the earliest possible stage to protect that person. So in summary, the human central nervous system is an ultra-sensitive biocomputer prediction learning machine, and its extreme complexity renders it very prone to significant disturbance in zero-G conditions. The cephalad fluid shifts and the abnormal intracranial fluid dynamics are a major contributor to the problems that we're seeing in the evidence so far. And this is a major safety concern for safety in long-term spaceflight. And there are also ethical considerations for what we might be putting astronauts through. But improved monitoring potentially could help to make safe flights safer with early detection and earlier management strategies. We might be able to reduce the long-term effects. But I think a lot more research is needed for us to be able to confidently send astronauts into space for long duration space flight. Thank you.
Thank you very much, Dr. Sen. Okay, so that concludes our final talk. Now we're just going to allow about 20 or 30 minutes for Q&A. So we've kind of taken together some of the questions that you guys have asked. We've tried to pick the questions that would most allow for interesting discussion between our panelists as opposed to more specific stuff on their lines of research. So this first question is more of a broad question to the whole panel, but from your perspective and from the perspective of your field, are we ready for long-term missions, i.e. either in space or to the moon or to Mars or to further to Mars? So anyone who feels like that they have a good answer, you can just go ahead and we'll go from there.
I can start.
Yes, sure.
I don't think that we are prepared for long-term space missions or deep space missions. I think that we are, in fact, after being in this field for 30 years, I have to say that I think that we are not doing a good job. We are not integrating studies. As I mentioned in my presentation, we have male data, not male and female data. We have poor ideas in relation to how medication work in space. We just basically use the same dose and time interval of medications that you use here on Earth in space, which is very poor. We integrated physiology in terms of studies are also very poor. I don't think that we are prepared basically. I think that we have huge gaps in terms of knowledge. And I am saying that, and I'm sad, in fact, because when I started my studies, when I was young, enthusiastic and young in the 1990s, I could see, let's say, that the space engineering, for example, it evolved so much, genetics, artificial intelligence, telehealth, digital health, and we are still struggling with very basic problems, I believe. So I think that the community, the scientific community of space life science scientists should revisit the way that we are designing our studies. For example, I spent a long time building space analogs and using them. Like in space agents, you have head-down tilt, and you have body suspension devices, and lower body positive and negative pressures box, and clinostats, and so on. But are we really simulating space? Are we really extracting data that can be then extrapolated to a space mission? And I'm telling that, and I'm still working with that. So I'm criticizing myself. I'm not criticizing, the others, and I'm criticizing myself. So I think that it is we are not prepared. That's my position. I think that we can go and can be successful even. We did that. We did that in the 60s when we went to the moon, and we had less knowledge, we had less technology, and somehow the Americans were successful. But I think that based on the knowledge that we have, if we were honest enough, we do not have enough knowledge to assure that someone will go to Mars, for example, spend time there and come back safely.
So the rest of the panel agree with that sentiment, or do you have any points to the opposition?
I mean, I would agree with that sentiment. I mean, I'm fairly new into the industry, but when I started the ESA Space Science Roadmap, we were actually struggling with just the title of the group. We couldn't agree on pharmacy or pharmacology or pharmacotherapeutics and pharmacological countermeasures was what we started it. So it just shows how much it's in infancy that we know about medications, that we even just had a long conversation about what should we call ourselves, and there is not a clear international harmonization of how this should be used. I also think that there's a lot of secrecy because we cannot solve the confidentiality of the health of the astronauts. I think there just needs to be a bit more transparency for researchers to have the data, to make conclusions, and to collect more data. So I think we can do it, but I'm not sure if we can sustain to be in space. That would be my take.
So I'd like to highlight what Lee just said. As I mentioned in my talk, we were recently running a meta-analysis of the studies in terms of the effect of spaceflight on brain and behavior. And it's impressive how small data are open and available to other scientists. So in other fields, replication crisis is a big thing. Sharing data and open science are big points, which looks like in terms of the space exploration is still quite behind. And I don't really understand why. And I think that a joint effort in making all our data open might help a lot with in solving the issues that Tyus was pointing out earlier.
Great, thank you. Okay, so for our next question, this one comes from Martina, and she's asking, can you provide a few examples of exciting technologies that you see as needed for space and translatable into applications on Earth, i.e. in rural or remote areas?
I guess I touched on one of those just towards the end of my talk, which is a relatively new technology called pupillometry. more and more of what we do, I think, needs to be non-invasive, and that's not, you know, within the clinical environment particularly, but in any environment, the safest way of monitoring any patient is through a non-invasive technique. There are an awful lot of invasive techniques that are available to monitor the brain, for example, but they come with risks because they're invasive. But a technology like pupilometry is completely non-invasive, quick, and semi-automated, and it gives you an idea of what's going on in the brain, because the pupils are give you so much information about what's happening inside the brain, and what the pressures are, what the pressure changes are likely to be, and you can track and trend that data over time, and you can utilize it not just for sort of acute diagnostic issues, but also for monitoring when the brain is recovering. So, for example, in concussion episodes in elite sportsmen, you can use what's called the latency period of the pupil, so the time that it takes to after it's been stimulated and then it expands, for it to return back to its normal size again. In patients who've had mild traumatic or moderate traumatic brain injury, concussion type episodes, the time that it takes for the pupil to start behaving normally again in terms of its latency can be somewhere from 10 to 45 days, maybe even longer. It's certainly been studied up to 45 days. And so that information can be used to tell you when things are starting to improve again. And that's the kind of, because we can't do blood tests in space. We can't feasibly be doing urine biomarker. Well, we could, but there are practicalities and practical problems with doing these sorts of trying to do these sorts of tests, not only in terms of the practicalities of carrying it out, but in terms of the sensor devices that you'd use to try and get quick results. So I would, in answer to that question, say that a pupilometer has a lot of potential for giving you a lot of information about what's happening inside the brain in a non-invasive and simple way, and that information can be communicated back to doctors terrestrially to perhaps advise on how that person should be managed from that point onwards.
If I can complement with my experience during my PhD here in London in the 90s, I was doing microgravity simulation, hypox exercise, and I was testing lung function. And one of the let's say the measurements that I had was arterial blood, and I tried to compare with arterial blood in space, and there is no blood collection, arterial blood collection in space. So they use the gases that we expire, to have an idea of our arterial blood gases, for example. And so after my PhD, I developed a blood collector that can take blood from the earlobe. So it is the technique was invented in 1940 something by two British physiologists, but could be very messy in space, because you have to cut the earlobe after making it full of blood and then collect the blood. And I developed this specialized syringe, let's say, that is a blood collector for the arterialized blood from the earlobe. And this is a good way, for example, to translate what is developed in space to applications here on Earth in medicine in any area, because it takes the whole procedure of collecting the blood and having the blood analysis. It is 5 minutes, and it's arterial blood that gives you lots of information that sometimes the venous blood does not give. And I have the patent for that, and it is, we developed it over the years. It started very big, 600 grams, and now it's 18 grams. So you can put in your pocket and use it with your patients.
That's really interesting. Yeah, that is really interesting. I guess the issue then is what you're going to measure. What biomarkers would you measure? I think only a small number of biomarkers of brain injury have been looked at in astronauts. Some neuronal markers, some glial cell markers, neurofilament light chains. I think as neuronal marker, glial fibrillary acidic protein as a marker of astrocyte damage. Beta amyloid protein, I think it's been measured. But we still need to, I think, all work together to try and define what are the best biomarkers, the most sensitive and specific ones, and also what the threshold, what the cutoff high versus low values are. And then, of course, what we would do if we had a positive or high result. All these protocols need to be thought through and developed, and it's no easy task. But certainly biomarkers may be in conjunction with, so you've got blood-borne information and so biochemical markers and physiological markers from the pupil together, along with the clinical assessment, might be a stronger, more robust panel or set of information together than any of those three on their own.
No, for sure.
Nice, thank you. Okay. So for our next question, this is from an anonymous person who said, okay, what is the possible disease burden that may be triggered by space traveling that may likely pose health morbidities within people on Earth? Are there research insights on how to manage disease transmission and infectivity within astronauts?
I really couldn't hear the last part of the question.
Sorry. Okay. I'll read the whole thing again. What is the possible disease burden that may be triggered by space traveling that may likely pose health morbidities within people on Earth? Are there research insights on how to manage disease transmission and infectivity within astronauts?
Yeah, well, the last part of the question is related basically to the immune system and how the astronauts react to possible germs like a virus or bacteria and fungi. It is interesting that it is well known now that the immune system decreases in space, so it is less active if you compare with here on Earth. But although they are in a confined environment and with lower immune response, they do not seem to present lots of, they are not more prone, let's say, to infections. They have infections. There are reports of intestinal gastroenteritis and skin infections, but the hygiene is very poor now somehow because there is no shower in space. That's something that I don't understand now. We are talking about going to Mars and we cannot have a shower in space, but in any case, I understand the logistics, the problem, but no solution, for God's sake. And in terms of diseases in space, it is because nowadays we still have astronauts that are extremely selected. The selection process is so intense for their mental health, their physical health, so that when they go into space, in terms of diseases, it's not the main issue now. In terms of correcting myself, now that I attend the lecture of Dr. Scott, awesome lecture, by the way. So because we always say adaptation, it's acclimatization, so it's wrong that I spend like 30 years saying it wrongly, sorry. But in any case, because you change your anatomy, not just your physiology, your anatomy changes in space, your physiology changes and your psychology changes. When you come back to Earth, we know that after 438 days, that's the record of Valery Polyakov, a Russian cosmonaut, we can basically readapt or reclimatize, that's the right word maybe, to Earth, and without morbidities. But can we stay longer? I think that one proof that we don't know much is the awesome lecture of Dr. Scott, that I think that the 5 questions that he asked, nobody can answer for sure. Anything. It's just suppositions.
Nice, thank you. Okay, so I've got another question from Doug Plata. So this might be more so Dr. Solomon's remit, but other people as well. But in terms of establishing colonies on other planets, is the possibility of using frozen embryos being is it a seriously considered option at the moment?
That's a good question. I mean, I think the possibility of having frozen embryos could solve some of the potential problems, of course, but you know, you still have to have successful implantation and gestation, pregnancy, childbirth, child development. So I think perhaps, but clearly we need to know much more about those other steps first. I mean, there's been a lot written about the possibility of frozen embryos for deep space, you know, deep space travel, deep space exploration beyond our solar system. So perhaps some baby steps to the moon and Mars might be warranted before embarking on the trip to Alpha Centauri. But I think the principle is at least conceivable, but so to speak, pardon the pun. But we need to make sure that all of the other steps will work before it makes sense to even consider it very seriously.
Nice, thank you. Okay, so just one last question to wrap things up. So we have a lot of students in the audience today, and if any of them wanted to get involved in the field of space medicine or the field of space in general, what would be your recommendation for any books or lectures or videos or any ideas at all as to how they would start to get involved in the field and get involved into the industry as well?